Okay, I'm going to present some of the comments and themes from the second session that we had yesterday, which was entitled to examine how we look at risk, how we determine risk, and specifically how we look at reasonably foreseeable risk and potentially determine reasonably foreseeable risks. And I organized the comments from yesterday into 7 themes, and I'll just begin by saying there's no way I can portray those themes, with the emotion and sentiment of Jeremy Sugarman or Leonard Glantz or Charles Vare or Ruth Macklin and the other panelists, but I'll try to do my best, and then Jeremy, you can liven it up. One of the main discussions that we had yesterday was actually over whether there is a need for guidance, whether there is a need for OHRP to release guidance on standard of care research, and different comments were made from there's no need to have guidance to yes, we should have guidance. That given that there was a controversy, that this is on everyone's mind. And I would say most importantly, and it was said in other sessions as well, is that we want medicine and medical practice to be evidence-based. And that's where we want to move forward. And in order for that to happen, we need to do research. And because this type of research is critical and essential, that guidance would be helpful. The guidance could be helpful. Whether this particular draft guidance is helpful, I think, is up for debate, and something that is a comment that was made yesterday. Related to that is that as we go forward, it's important to involve all the major stakeholders. And one of the points that I have written down, and it was reinforced in the public comment period, is it's really important to involve patients in this discussion that we're having about the draft guidance, but it really goes much, much beyond that. And comments were made yesterday that we really need to understand the needs and interests of patients, and those patients who are considering volunteering to participate in a research study, that we should not be second-guessing what information is important to them, and involve them in that process. And the discussion went from involving them in terms of assessing, what they want to be informed about, all the way to, they should be involved in even designing studies and involved in looking at study design. The group yesterday talked about defining standard of care, and that has actually been a topic that's come up in all 3 of the sessions. The draft guidance does offer a definition of standard of care. It speaks about standard of care in a broad sense of medically recognized practices. But one of the points that was made yesterday in session 2 was that that definition in the draft guidance is going to be difficult to implement because medical practice differs on so many different levels. If you're looking at something nationally or at the state level, you're looking at it locally, within hospitals, depending on the patient population, it varies, and that variability is likely to lead to inconsistency then among the IRBs in how they're going to judge these research studies. So in addition to perhaps keeping a broad definition for a standard of care, having some criteria or providing some guidance that will help IRBs, would help sponsors of research, would help investigators to evaluate local practices in this context of standard of care research would be helpful. We discussed risks yesterday, and reasonably foreseeable risks. What was interesting about that discussion is the requirement to disclose reasonably foreseeable risks is a regulatory requirement, as nothing has changed about that requirement, but it has now become much more of a topic of discussion, and as a result of the study we do not mention. And it's really important for IRBs, and I would say for IRBs, because I think that IRBs are going to be ultimately held responsible for interpreting that regulation, to have some sense of what is reasonably foreseeable. The comments were offered about what is reasonably foreseeable, all the way from, it's hard to define reasonable, it's hard to define foreseeable, to suggesting that maybe if we talk about it in terms of it's a material risk, and that it's something that is based on the evidence that we have at hand, that might be helpful. An idea was proposed that perhaps we look at frequency as a way to define reasonably foreseeable. Like the other groups, we talked about potential benefits, and that the draft guidance is neglectful. And that's my word. It was not a word used yesterday, but it is neglectful in not addressing potential benefits, that when we undertake research, any type of research, we are undertaking that research because we do believe that there are potential benefits to that study. And so to only focus on risks and not to consider the benefits from the knowledge that is gained, would be potentially gained in this type of research, or benefits, direct benefits to individual patients, is failing to focus on a really important part of the reasons that we are undertaking these kinds of studies. There was a fair amount of discussion about informing prospective participants, and I think that again, the discussion ran along a continuum of some information, maybe using the word just informing or just disclosing, to having a more full consent process. I think that 2 points about that. One was to not overburden prospective participants with information. Too much information is not information. And so we're looking for and striving for the right balance of information. There were several comments made that if we could figure out what are the reasonably foreseeable risks, which are not all the risks, but all the reasonably foreseeable risks in the study, that those should be disclosed. And the last point was to just reinforce this notion that one size doesn't fit all, that in this type of research, there are many, many different types of standard of care studies, and it might not be possible to come up with only one set of criteria for reviewing those studies, or one set of criteria for the consent process. And we should be sensitive to that issue and not rush to come up with something that's not going to be workable in many studies. And there are others here from session 2. If you have any additional comments, would love to hear them, and if I missed something.
So I think you captured it nicely, Marjorie. That was great. One theme that I think ran through our discussions yesterday was the idea that some of the issues that we are addressing have been problems or issues faced in research ethics more generally and are not particular to the question of research in the standard of care setting. And so we can't expect some type of guidance to solve all these issues about which we've been thinking about for a while. And I think that was probably the main theme that just came through.
Okay.
Oh, yeah. Oh, and on the point, I think your last point, that a slight tilt to the frame, if a guidance is going to be reworked from the current draft to another draft, the draft should be sensitive to the different types of research in usual care settings or standard of care research. So not necessarily a no-go, but it has to be adequately sensitive to those settings, and that may be helpful in fixing it.